I apologise for my late arrival. I underestimated the traffic. That's a pretty weak excuse, I'm sorry. Okay, so the point of my talk tonight is to talk about counter-transference reactions that may arise in clinicians when working with people in therapy and also with people with BPD. Turning the PowerPoint off apparently. Yeah. Okay. So my name is Mitchell Howarth. I'm a psychologist in private practice. I'm in North Sydney and I also work at Mossman Private Psychiatric Hospital in the outpatient program there, the DBT outpatient program. A significant proportion of people in the program have BPD, as you'd imagine, because it's a program that was initially developed for people with that condition. I'm very interested in the disorder itself and also in its treatment. I suppose I have most of my experience has been in DBT, but I'm also interested in psychodynamic ideas, which is where a lot of this is drawn from. Just before I get started, I thought I'd just give you a summary of what I would really like you to leave tonight with. And that is clients with and without borderline personality disorder may evoke negative reactions in you as clinicians. It's just a given. Any psychologist is going to know that that's going to come up in therapy. It's going to happen. The most important thing to remember is, apart from knowing that it will happen, is that in managing these reactions well, the therapeutic alliance, the relationship you have with the client, will be improved, which is the most important thing in therapy. And perhaps unsurprisingly, because of that, client outcomes are improved also. So what is counter-transference? It has a psychoanalytic origin, and that it came out of that discipline. And there are many different definitions for it. So one definition, known as a rather broad definition of counter-transference, is any reaction that a therapist has to a client, so any reaction at all. Other people are more narrow in their definition, in that they believe that counter-transference is any reaction that a therapist has that arises from the therapist's own issues. The working definition that I'd like to use tonight is that I'd like to think of counter-transference, or rather emotional or cognitive or behavioural reactions in general. I want to quantify counter-transference as any reaction that one has when working in therapy that has the potential to disrupt the alliance, the relationship, or that has the potential to interfere with client outcomes. Okay, so counter-transference reactions in clinicians can involve cognition, such as judgments. There can be emotions such as anxiety, or they can be overt behaviours like criticism. Tonight I'm really going to emphasise the behaviours because, as I say, it's not so much about trying to avoid the cognitions or the emotions. They're a given, they're just going to come up. It's how we manage the behaviours that's really going to predict the better relationship outcomes and the better outcomes in the quality of life of the clients. As the causes of counter-transference can be the client's behaviour, so as I say, it's not always the therapist's issues that are going to be explaining their emotional reactions in session. Sometimes being criticised by someone, or, for example, it's going to bring up anxiety in most people. It's going to bring up a sense of defensiveness and distance in most people. So it's not that you necessarily have to have an issue around that for those emotions to be evoked. However, therapists' own issues, like their own anxieties or their own unresolved conflicts, if criticism for you is something that's quite hard to stomach, and it is for most of us, but some people have more difficulty than others, some of the time managing them, it's important to know that. So why does counter-transference matter? Clients affect us, as I said before. You're going to have counter-transference reactions, it's just going to happen. BPD clients specifically may evoke negative reactions. So research has confirmed that, but this applies to all clients. Again, I don't think we need to just talk about people with BPD specifically, it's all clients. Negative reactions will come up. And as I said before, managing the reactions well predicts better working alliances and better client outcomes. Okay, so the most common reactions, or counter-transference reactions, in working with people with BPD are guilt and rescue fantasies, which I'll go into in a minute, and in addition, another cluster of reactions relating to anxiety, anger, and a sense of helplessness. Now, these are taken from Gabbard, 1993, and he quantifies these as the most common reactions, but I'd also like to say that these aren't necessarily common. I work in Mossman Private Hospital. I would say that I don't experience much of these most of the time. It's an utter pleasure to work in Mossman. I wouldn't be there otherwise. So, rescue fantasies. Rescue fantasies are believing that one must save or take responsibility for the client. These can come up in us from time to time. Again, this can relate to maybe unresolved issues that one may have, although sometimes people present as being in quite dire life situations, and it makes sense that as empathic human beings we're going to want to help them. And so some of the reasons why we might have feelings of guilt and rescue fantasies is that we might have a sense of guilt or obligation to the client. We may view the client as helpless and incapable of solving their own problems. Or we might want to be the good parent or the good carer that the client's never had. Oftentimes, people with DBT come from they have awful traumatic childhood and early life experiences, so it makes sense, as I say, as carers that we're going to want to help people. And again, this is more, I'll get into this in a minute, and it's not so much about completely cutting this off, it's about knowing when we're going a bit too far and knowing when to pull back. So the problem with guilt and rescue fantasies is that they can prompt inappropriate approach behaviours. So I'm going to quantify the kind of unhelpful counter-transference behaviours tonight in these terms. So it's either approach behaviours or withdrawal behaviours. So approach behaviours are more like doing too much. So the examples can include things like making decisions for the clients, taking responsibility for them, doing more than one usually would, unnecessarily extending sessions, lessening fees. Again, this is more relative to your work as a clinician in general. I extended a session last Thursday for an hour with someone, but I thought that it was relevant. I saw it as part of the treatment. So it's not that extending sessions or lessening fees is necessarily a problem. I mean, lessening fees, some people have restricted means. Some people are students, so it's okay in some instances. It's more about what's behind it, what's driving it. The potential problems that can arise with these guilt and rescue fantasies and the behaviours they prompt is that it can prevent a person from learning self-management skills. I mean, a big component of DBT or CBT is really teaching people the skills they need to manage the intense emotions that they have. And if we're depriving them of the opportunity to do that, it makes sense that they're going to be deprived of the opportunity to do that. I think we may, in doing too much in therapy, we're preventing people from strengthening their self-efficacy beliefs. You're not going to leave therapy necessarily with as strong a belief in themselves to be able to cope, which is a lot of what predicts success in therapy, especially the cognitive behavioural therapies. People tend to come away from them with the belief that they can cope, they've coped before, and that they can do it again. Okay, so moving to the other cluster of symptoms, the anxiety, sometimes the anger and the helplessness. This can be prompted sometimes by the suicidal gestures or threats that can sometimes happen, which is one of the symptoms of the condition, although again I'd say that really doesn't happen, at least for me, really that much. Sometimes people can have a sense of maybe entitlement for special treatment, maybe pushing a bit more. There can be some hostility or criticism, especially if the person feels like you're not on board with them and you're not caring for them enough. And there can be also litigation concerns that can come as well. Most of these things come from inexperience, though, I would say, on the part of the clinician. And these things understandably can prompt unhelpful withdrawal behaviours. So if one feels criticised, it makes sense that one would want to disengage from the person and become defensive. And at times that can also prompt things like at least an internal sense of criticism and derision of the person, and sometimes that can leak out. And you can imagine what the ramifications that can have for the relationship. And I'll go into some of them here. So it's invalidating for the client, obviously. It can further the client's sense of estrangement from other people. And it can also compromise our empathy and our positive regard for the person, which are core conditions that are incredibly important for the treatment. And research shows actually more important than the actual specific ingredients of the treatment that you're doing. These relational factors are especially important. So the goal of managing counter-transference is to manage the internal reactions that arise, and they will arise, so as not to act them out. One thing that can be helpful in this way, I think I view it as an important prerequisite, is a sense of self-awareness. And one component of this is a non-judgmental awareness of one's thoughts and feelings as they arise in the moment. So it's important to know maybe there's a sense of, there is some anxiety there. You're noticing a sense of like you're wanting to put distance or kind of push the person away just subtly. Maybe you're noticing thoughts of criticism yourself. Maybe you're feeling hurt, maybe you're feeling attacked. It's important to notice these feelings. Examples of ways to practice this non-judgmental awareness is through things like mindfulness, which is essentially the non-judgmental awareness of your experience in the moment. In the psychoanalytic literature, they refer to something called free-floating attention, which is a similar process wherein one is in the moment, and present with the client. Another aspect of the self-awareness piece is self-insight and support. So you might notice that certain clients in general trigger you in certain ways and in characteristic ways. And maybe you can liken that to early life experiences or your own issues that are going on. And in instances like that, I think personal therapy can be helpful, as well as clinical and peer supervision. Conceptualizing ability. So this is the ability to see things that are happening in the moment and putting essentially labels on them or understanding them within a formulation that you have of the problem. Diagnostic criteria can be helpful too. It can be helpful in this way, in that it aids understanding of what can be happening in the moment, in yourself and in the person. It can help your empathy yourself, at least it helps mine. It can also lessen overwhelm. So I think some of the more intense symptoms that you might notice in clinical practice, if you understand this within a diagnostic framework, it can lessen your overwhelm. It gives you more of a sense of objectivity. What I also like to do in session is that I'd like to use my own reactions as data for how other people might feel. It's not uncommon for someone to come into treatment and to be dissatisfied with the nature of their relationships. And I think, first of all, attending to your own reactions, your own thoughts and your own feelings, and then kind of considering that in the context of the client's presenting problems. So it could be, for example, that a client has difficulty maintaining relationships because they feel like people are consistently letting them down. Because they feel let down, they're prone to getting quite angry and agitated and hurt, and the way that they manage that is by attacking someone or criticizing someone, and that may manifest in the session, and those feelings can come up in you, and then you can wonder in yourself if this kind of thing is happening on the outside, and I think you can present that in a really sensitive and ideally helpful way to the person. I think also taking things like, so manipulation, I've deliberately put that in inverted commas, because there can be stigma, especially around this population. It's super unhelpful. It's also, it's really not fair, actually. And I really like to, I think one of the real strengths of DBT is that it phrases everything, or every behaviour rather, in terms of how effective it is in meeting a person's needs. So manipulation in some sense is essentially an ineffective strategy for meeting a person's needs. But it's important to remember that manipulation sometimes works, so it's not completely dysfunctional. Doing something to kind of elicit a response in someone, or not doing something to elicit a response in someone, it's still eliciting a response in someone. And if you have an unmet need and that behaviour is getting that unmet need partially fulfilled, it kind of makes sense that it would be perpetuated. It's going to go on. And it's important to have that kind of conversation with the person without going manipulative. Unhelpful. Anxiety management. This is the last slide that I have. I think it can be anxiety provoking working with people with BPD. It's as we know, there can be high rates of self-harming and suicidal thoughts and suicidal gestures, and some people attempt and complete suicide. For that reason, it's really important to assess risk well. If I feel that someone in the session is at risk or they disclose to me suicidal thoughts, I'm going to inquire more. I'm going to inquire more about the plans that might be forming, the intention that the person has to act on these, and we're going to talk about supports and what they can do before we next meet to ensure that they can make their next appointment. And I think this last final slide is a nice way to end it, in that most clients that you'll see in practice with BPD do well with well-meaning non-experts. This has been particularly helpful in managing my anxiety because it kind of tempers the perfectionistic side in me. I realise I don't have to be an expert. I need to be skilled. I need to have certain things that I'm doing. I need supervision. I need support around me. But I don't have to be the perfect person. And that's helpful, at least in managing my anxiety, I guess. And I'd also like to say, I think probably finishing, I think Jonathan, you mentioned that sometimes we notice that I think the reason why we're all here is because in some way BPD has affected our lives. I think people are quite quick to talk about BPD being in our families. It's quite removed. It's just like, I mean, I might be the only one in the room, but who hasn't identified traits of BPD in themselves? Like the mood fluctuations, the anger when you're in Sydney traffic trying to get to a presentation that you're doing but you're late for. Yeah. So I think it's important, to really identify these kind of symptoms in yourself. That it's just, I think it's a way of kind of bridging bridging that gap between the client and you. I really think it's about, in therapy, it's really about getting closer, but doing it in a way that serves the client. I think all of managing counter-transference, I feel, at least in my work, is it's all aimed at improving and maintaining the relationship I have with the person. Because from there, you're able to do really anything. And I said that the kind of skills that you do, yes, they're helpful, but the most important thing is the relationship. And I think if they have that, it's a really great base for them to model other relationships on and to really improve from. So I think I've said my piece. Thank you very much.
It's actually not a question, just a comment really. Thank you for the presentation. I was just wanting to elaborate on the importance of the counter-transference in relation to boundary transgressions too, because you were talking about being nudged into certain behaviours, but as Gabbard talks about the slippery slope, one of the real risks is actually being nudged into serious boundary transgressions, and a lot of complaints to the Healthcare Complaints Commission are about these issues. And I think stressing supervision, as you did, is very important. I think supervision when working with this client group is very important.
Thank you very much, and I think we'd all agree that we need clinicians to be in good form, feeling supported and healthy themselves if they're going to be able to do what they need to assist people.
Did you want to comment on that?
Yeah, certainly. I think I was kind of reflecting on this topic as a whole, and I think the best way to manage counter-transference is to be passionate about the work. It's easier to tolerate the kind of difficult feelings that come up with you when working with people with BPD and with working with people in general when you're passionate about the work. I mean, the passion's there. You value the work, so you can tolerate it. It's quite easy to kind of put yourself through all of this because it's worth it. It's worth it. Yeah.
Thank you very much.
Thank you.
And I'd have to say that those two key areas of anxiety and helplessness and also excessive guilt are exactly where most carers of people with BPD spend a lot of time personally, because it is difficult to know what to do to help a person, and it can be very anxiety provoking. But